by Dr. Sharma, who's going to go over the complement pathways and C3G pathophysiology. We'll take a break between each of the talks just to kind of take some questions from the audience, also from our virtual audience that are trickling in. And then we have a talk by Dr. Brad Dixon, who's going to go over nephritic factors, and then by Dr. Carla Nestor, who's going to go over the trials and the therapies. And I'm hoping that we have at least an hour afterwards, because we have some real world clinical cases that we want to talk through and kind of see how everybody is handling those and where we are going, what our unmet needs are. So with that, I am going to invite Dr. Sharma to get us started. Dr. Sharma is a clinician educator in the Division of Kidney Diseases and Hypertension and the co-director of the Glomerular Disease Center at Northwell Health. She also directs the Galdi Fellowship in Glomerular Diseases and Onconephrology and Glomerular Disease Research and Trials Division. She has authored numerous peer-reviewed articles on C3 glomerulopathy and has given talks nationally and internationally as part of ISN and the National Kidney Foundation. So, Purva, the stage is yours.
Good evening. So I'll get started on the overview of the complement pathways and C3G pathophysiology. All right, so C3 glomerulopathy is a disease process that is characterized by alternative complement pathway dysregulation. It needs a kidney biopsy that shows C3 that is at least 2 orders of magnitude higher than the other components. So it doesn't have to be isolated C3, it just has to be 2 orders of magnitude higher, so dominant C3 staining than the other components. It needs to be at least 3 months after an infection. So the most common differential, as we know, of C3G is an infection-associated GN. So you want to make sure that it's 3 months, a reasonable amount of time has passed since the last infection. And then it can be dense deposit disease or C3 glomerulonephritis. So the first time C3 glomerulopathy was given that name was in 2013, in which the consensus report said that C3 glomerulopathy should be used to designate a disease process due to abnormal control of complement activation, deposition, or degradation. And it's characterized by predominant glomerular C3 fragment deposition with electron-dense deposits on EM. But remember, this is not a new disease. It's been called very many names in the past, but this was the first time that was actually given the name C3 glomerulopathy. And then there was also in 2017 an atypical HUS and C3 glomerulopathy conclusions from a KDIGO controversies conference that looked at a little bit more, it looked at C3 glomerulopathy in more detail. So I'm going to go over the complement system just very briefly. We know that complement system is part of our innate immunity. So the classical and the lectin pathways are activated when the body encounters a foreign pathogen, right? So classical pathway is activated by an antigen-antibody complex, and lectin pathway is, again, very similar to the classical pathway, but it's activated by, a carbohydrate residue on the surface of the pathogens. And ultimately, it leads to the formation of C3. Now, unlike the classical and the lectin pathway that need to be activated, the alternative pathway is constitutively active at low levels in the body, which is called the C3 tickover. So really what it means is that small amounts of C3 activation or C3b production is always happening in the body. There's a regulation of C3b production. So C3 gets converted to C3b by an enzyme called C3 convertase. And when the C3b is formed, the factors B, D, and P sort of propagate this whole cycle of C3 to C3b production. And a lot of the C3b gets produced. So again, very low levels of C3b are always being produced. But if the body needs more C3b, so in the face of infection, you will need more C3b, and more is being produced. And what does the C3b actually do? What it does is basically opsonization. So it coats the surface of the bacteria, and it can be easily detected by the cells that need to take care of it. Now, what C3b, when it's overactive, really what it does is it combines with the other pathways like C3a and finally forms a C5b-9, which is your membrane attack complex that leads to cell lysis. So really, alternative pathway is constitutively active. Classical and lectin pathways have to be activated. And so you can see here that there's a, there's a tight regulation between the activation and the regulation of C3 to C3b conversion. I'm sorry. So how is the regulation of C3b achieved? So there are negative regulators of C3b. And what are those negative regulators? There are factor H, factor I, membrane cofactor protein, complement receptor 1, again, and factor I. And factors B, D, and P are actually propagating the cycle of C3 to C3b conversion. So when there is the need for C3b, you produce more C3b. But when there's no need, there's little amounts of C3b. But this process, can become overactivated in patients with C3G. So our job is to figure out why this process is being overactivated. So there is very delicate balance between activation and control of the alternative pathway. So if there is too much activation or insufficient regulation, that leads to inflammation. And if there is too much control or insufficient activation, of course, that's not good when you encounter an infection. And what are the mediators of that imbalance? There could be mutations, polymorphisms, autoantibodies, environmental factors, and this is sort of the gist of what this talk is about as well. So this is a very sort of elegant paper looking at genetic and acquired drivers of C3G. So these are the tests that are potentially useful in patients with C3G. But it also tells you what are the different factors that can lead to C3G. So there's autoantibodies and genetic factors. So C3 nephritic factor, C5 nephritic factor. So we know that most of the C3G is actually an autoimmune disease, which is it's an antibody-mediated disease, and it's mediated by autoantibodies called nephritic factors. And then there is genetics. There are mutations in the pathways like complement factor H, C3, etc. So as I said, the acquired defects are the most common defects in C3G. So C3 nephritic factor, C5 nephritic factor, C4. Then there are anti-factor H autoantibody, anti-C3b autoantibody. And then there are genetic mutations, but the genetic mutations are less frequent than the acquired defects. So genetic variants could be defects in C3, complement factor H, CFHR1, complement factor B, and complement factor I, among, of course, many others. So how does this translate into what we see? So when you do a kidney biopsy, you see an MPGN pattern on the kidney biopsy. And if there is dominant C3 staining is the first question. If there isn't, so no. You look at the immunoglobulin staining. So if the immunoglobulin staining is present and dominant, it's classified as immune complex MPGN. So it is indicative of classical complement pathway activation. And the classic reasons why this gets activated are infections, autoimmune, neoplastic. So you got to rule some of these factors out when you see classical complement pathway activation. And if the immunoglobulin staining is not there, or the C3 staining is more than 2 orders of magnitude, it signifies alternative complement pathway activation, and as classified as C3G. Now, C3G can be classified into different types, so dense deposit disease and C3GN, depending on whether there's presence of highly dense intramembranous deposits. So dense deposit disease does have them, and C3GN has different location of the deposits. So diagnosis of C3G can really only be made on immunofluorescence, right? So light microscopy patterns of C3G can be a variety of them. So Most commonly, we do see membranoproliferative pattern, but it could be mesangial-proliferative, endocapillary proliferative with crescents. The immunofluorescence shows strong granular staining for C3, so at least 2 orders of magnitude greater than whatever else is there, IgG, IgM, IgA, C1q. And then electron microscopy in dense deposit disease will show dense intramembranous deposits. In C3GN, it will show light amorphous, mesangial, paramesangial, subepithelial, subendothelial deposits. So all different kind of locations in patients with C3GN. So I know we're having a talk later, so I'm not going to spend time on nephritic factors, but really nephritic factors are just autoantibodies that stabilize the alternative pathway C3 convertase, which is C3BB, preventing its inactivation by the complement regulators. So really the alternative complement pathway is going into the overdrive mode because the C3 convertase is being stabilized. So it's not really being degraded, or it's not being able to be regulated by the negative regulators of that enzyme. And then there's C5 and C4 nephritic factors as well. I just want to spend just a minute or two on the acquired drivers of C3G. So one of the important acquired drivers of C3G are monoclonal gammopathy, especially in adults or patients more than 50 years of age. So monoclonal immunoglobulins, they act as nephritic factors, really. So they are also prolonging the C3 convertase enzyme and sort of putting this pathway into overdrive mode. And treatment of monoclonal gammopathy may stabilize kidney function and remission. And then the genetic causes of C3G. So there are lots of genetic causes of C3G. Again, less common than acquired causes, but still a very important, very important to do. So gain of function changes in the complement activation proteins, factor B and C3, loss of function mutations affecting the regulatory protein. So the negative regulators of the complement pathway will lose function, such as complement factor H, complement factor I that I showed earlier. Mutations in C3 that will impair the ability of complement factor H or CR1 to downregulate the C3 convertase activity. So that's one kind of genetic mutation. And then there's genomic rearrangements within the complement factor H related genes that don't affect the CFH gene have also been reported in the familial C3 glomerulopathy. So what are the most common triggers of C3G? So irrespective of the biopsy, the triggers can be varied. So I already said monoclonal gammopathy is one of the triggers, infections, and autoimmune conditions. So whenever you see C3G, sometimes it is triggered, which sometimes makes it tricky. There might have been a recent precipitant in the form of an infection that might have led to the C3G episode. And then the apolipoprotein E, there's some new data from Dr. Sethi's group that really looks at apolipoprotein E that is enriched in the dense deposits, and it might be a marker for dense deposit disease. So I think we'll learn about this some more probably later. I think that's it. I just had 5 minutes,
That sounds good. That was a nice overview, Purva. Thank you so much. So I think we'll hold off for the questions until Brad's talk, because he's covering the nephritic factor, which is actually really one of the more important causes of C3G. So it is my pleasure to introduce Dr. Brad Dixon, who is currently a professor of pediatrics and medicine and the chief of the section of pediatric nephrology at the University of Colorado School of Medicine and Children's Hospital, Colorado. Dr. Dixon's clinical interests focus on complement-mediated renal diseases such as atypical hemolytic uremic syndrome and C3 glomerulopathy. He's also an investigator in several clinical trials of complement-targeted therapies in these diseases. Welcome, Brad.
Thank you, Dr. Java, and thank you for the opportunity to speak to you this evening. The charge that I've been given is to talk about nephritic factors, and I think it's a particularly challenging charge to make myself understand nephritic factors in 20 minutes, moreover, helping you all understand them. So we'll discuss the what, how, where, and why of nephritic factors. And these are my disclosures. So to start off with a polling question for the clinicians in the room in particular, how many of you have sent nephritic factor testing in evaluation of a patient with C3G?
Yeah, just a show of hands is fine.
So how many yes? Okay. How many have not had the opportunity to send nephritic factor testing? Okay.
It's okay. It's fine.
Okay. How many ask, what is a nephritic factor? And if you ask that, you're in the right room, and I'm about to tell you. And if you ask, what is C3G? You might be at the wrong conference. ASH is actually next month. Okay, so we'll start out with the what of nephritic factors. So nephritic factor was first described by Spitzer and colleagues in this landmark paper in Science in 1969. The senior author on this paper was Clark West, who is a pediatric nephrologist in Cincinnati. So I have a deep amount of affinity for this particular paper. But the description was that there was an unknown substance in a patient's serum that caused overactivation of the complement system when it was combined with normal human serum. And subsequently, other work identified this unknown factor as an IgG antibody, and then later that this IgG antibody had affinity specifically for an assembled C3 convertase. So from this early work, we now have recognition that there are several subtypes of nephritic factors, and it depends on the affinity towards the specific C3 convertase. This was already introduced to you a few minutes ago by Dr. Sharma, but the C3 nephritic factor C3nef stabilizes specifically the C3 convertase of the alternative pathway, which is C3b-BB, and I have that indicated here. The C5 nephritic factor, which has gone by some other names historically, stabilizes both the C3 and C5 convertase C3b, BB, C3b, and this convertase is dependent on the presence of piperidine. And C4 nephritic factor stabilizes the C3 convertase of the classical or lectin pathway C4a, C2b. So what are not nephritic factors? There are other autoantibodies that recognize individual complement components, and this includes factor H autoantibodies. It's an interesting paradox that you can find factor H autoantibodies both in C3G as well as atypical hemolytic uremic syndrome. And what's really behind that paradox is specifically where the autoantibody is binding and ultimately dysregulating, where autoantibodies that are found in atypical HUS bind more to the cell surface recognition, the C-terminal portion of the molecule, versus those found in C3G where they're binding to the regulatory domains closer to the N-terminus of the protein. Autoantibodies to factor B and C3b have been also described in a minority of patients with C3G, and these autoantibodies bind the component of the convertase, but not the assembled convertase as a whole. So what is the function of nephritic factor? So once these nephritic factors bind to the C3 convertase, which normally has a very short half-life in plasma and on a cell surface, the half-life is around 90 seconds. And once this convertase is structurally stabilized by nephritic factor, the half-life is greatly extended and allows for this unregulated activation of complement. And ultimately, the pathogenesis that follows from this is complement fragments that are generated by this overactivation ultimately are deposited in the glomeruli in various compartments of the glomerulus, leading to distortion of the glomerular architecture and the histopathologic changes that we see on biopsy, and ultimately proteinuria, hematuria, renal dysfunction. So there's been some recent evidence that has further explored the function of nephritic factors, and this came from Veronique Fromeau-Baki's group in Paris, where they used a Luminex-based assay that identified that nephritic factors may not only stabilize the complement of the C3 convertase, but it might actually augment the formation. And so they did this assay first looking at the formation of the C3 convertase by assembling C3b on magnetic beads, then with addition of components including factor D and factor B, were able to identify the BB fragment on these beads. And they found that a significant subset of patients with C3G had nephritic factors present that held this function. And also, but not entirely overlapping, they found patient IgG that stabilized the complex by assembling the full convertase and then allowing decay of the convertase and measuring this through the same Luminex assay. Okay, so our next polling question, and this is a statement, not a question, so grammatically a little incorrect perhaps. Identifying nephritic factor in a patient with C3G will change my clinical approach. How many say yes?
It's okay.
Unknown? Yes. No? What is a nephritic factor? Were you just sleeping? I just said what. Anyway. Okay, so now we'll focus on the where of nephritic factors. Where is it important to test for nephritic factors? As was already really well illustrated, nephritic factors are really the predominant dysregulating factor that we find in C3G in about 80% of patients with dense deposit disease, and depending on the case series that you read, around 50% of patients with C3 glomerulonephritis. And nephritic factors can also be identified in a significant subset of patients with immune complex MPGN. And so even though the consensus guidelines, the consensus report very clearly delineates these two as distinct entities, the fact that we can find nephritic factors with similar frequency in IC-MPGN as we can in C3G, and the same is true for genetic drivers of complement dysregulation, may suggest ultimately that these diseases lie on a spectrum rather than being truly two completely separate and distinct diseases. And this is especially supported by many observation that many people, including myself, have made, that patients who are biopsied at the beginning of their disease, their biopsy subsequent to that and a serial biopsy may indicate the other disease process. So did a patient's disease really convert from one rare disease to another, or are these diseases fluctuating on a spectrum? So where might there be therapeutic implications for identifying a NEF? This is still largely with a strong question mark behind it, because there really haven't been to date any therapeutic implications. But I leave this as a provocative question. So I think there is a sense that because nephritic factors are autoantibodies, conceptually, it makes sense that if you can target the autoantibody, ultimately you may reduce or eliminate the dysregulation that happens, complement dysregulation that happens. And the initial reports were using B-cell depletion with rituximab, and these reports were largely unsuccessful at achieving disease remission. There was one report where a patient was able to achieve a better renal outcome, but it's notable that in this case report, the patient was not only treated with rituximab but also belimumab. So perhaps a more deep reduction of B cells than with rituximab alone. Well, what about beyond the B cell? What about plasma cell therapy? So there have been some case reports of targeting plasma cells as well. There's a case report with the use of a proteasome inhibitor, bortezomib, in a pediatric patient with C3G who had failed MMF and corticosteroids and ultimately failed rituximab. And in this case report from a few years ago, they found that the C3 nicely normalized with the initiation of bortezomib, so perhaps a little bit of a proof of concept there. But in this case, the proteinuria was largely unchanged. And then a newer agent to target plasma cells, daratumumab. So there are a few case reports of daratumumab use. This is largely in a perhaps distinct disease, proliferative glomerulonephritis with monoclonal immune deposits, or PGN-MID. And in this particular case report, the patient with that disease, arguably different than C3G, was C3NF positive. So in this case, the C3 normalized, and I'll sort of point to the C3 curve. It's a little bit of a busy graph, but once daratumumab was initiated, the C3 normalized, and the proteinuria also had a nice response as well. But again, these are anecdotal reports, really nothing to draw firm conclusions from. I also want to leave a little bit of provocative data that there could be some implications in the choice of complement-targeted therapeutic. This was a poster at ASN a number of years ago where pegcetacoplan was used in vitro in patient sera from patients with C3G who had nephritic factors. And in this in vitro work, complement convertase activity was reduced in vitro in these samples where pegcetacoplan was added, and this is graphically shown here. So perhaps there could be some implication, although I think this needs to be borne out with clinical trial data more than in vitro studies. So where is there controversy in testing for nephritic factors? One is that there is still no clear association between the magnitude of nephritic factor, the titer, and disease activity. There's also no clear association between nephritic factor as the identified complement dysregulating factor and long-term renal outcomes. We don't have that. Lastly, nephritic factors can be identified in patients with other complement-mediated hypocomplementemic diseases like post-infectious GN and lupus, but even in healthy individuals. And there was a recent paper by one of my co-panelists and a graduate student working with her, I believe, that actually identified anti-C3 convertase antibodies in the vast majority of normal individuals. And these are not functionally active C3 convertase antibodies, so they bind to the convertase without stabilizing and causing dysregulation, so perhaps suggesting that this represents a precursor to nephritic factor in the dysregulated state. Okay, last polling question. I know what lab I or my institution sends nephritic factor testing to and how it is performed there. How many know exactly where their lab sends nephritic factor, or they themselves send nephritic factor, and what methodology is used to perform it there? Any yeses? One, sort of. Probably someone who runs a lab. Two, probably someone who runs a lab or is it lab adjacent. How many say no? A good number of folks. Why does it matter? Well, so in the next few slides, I'm going to talk about the different methodologies of nephritic factor, and this is where it gets really complex and sticky, so bear with me. So how are nephritic factors identified? It's complicated. There are multiple assays, multiple laboratory methodologies that have been used historically and recently. And I think the catch is that these various assays have different sensitivities and specificities. And so depending on the specific assay that's used, it can ultimately influence the published incidence of nephritic factor in a patient cohort. So if there is a less sensitive assay, your incidence of nephritic factor may ultimately be lower than a more sensitive assay. And ultimately, the presence or absence of nephritic factor driven by the specific methodology in question could ultimately influence our therapeutic or prognostic understanding of their presence. So perhaps the gold standard, the original method of measuring nephritic factor as a laboratory diagnostic test is the hemolytic assay. It's largely considered a gold standard. It's a functional assay, and the way this assay is done is by assembling the C3 convertase on the surface of a sheep red blood cell, and that convertase is ultimately stabilized with IgG either within a patient's serum sample or more cleanly with purified IgG from patient serum. And then ultimately the red blood cell is resolved, the result is resolved by adding rat serum, which provides the terminal complement components, leading to lysis of the red blood cell, and then red blood cell lysis is measured spectrophotometrically. So this assay, this hemolytic assay, can be altered or modified to identify the specific nephritic factor in question. So if you leave preparedin out of this reaction, ultimately that's a more specific assay for C3 nephritic factor. If you add preparedin to the assay, you're going to be probing for this C5 convertase, so that's a more specific assay for C5 nephritic factor, or you can assemble the classical and lectin pathway convertase on the red blood cell, and that's a C4 nephritic factor. We can also functionally look for C3 nephritic factor indirectly by measuring the capability of a patient's serum to cleave C3 by immunofixation electrophoresis. And in this method, a patient's serum is mixed with normal human serum, and then the C3 convertase that's formed in that fluid phase, in that test sample, will lead to C3 cleavage that you can then identify by performing electrophoresis and quantifying the degree of C3 fragments to whole C3. And then there are also methods, published methods, that can identify C3 nephritic factor, but only as an antibody that bind to the assembled convertase. And these are largely ELISA-based assays, but they don't confirm the functional ability to stabilize the convertase. They're only measuring binding, not the ability of the convertase to cleave C3. So the why. Why is it important to identify nephritic factors? There's still, I think, a little bit of debate about like what the clinical implications of C3 nephritic factor when you identify it is. However, there is some beginnings of data that suggest that the intensity of nephritic factor dysregulation, what in this manuscript was called a severity score, does seem to correlate with proteinuria. So the greater the intensity of complement dysregulation, the more severe the proteinuria. And then in the paper I mentioned earlier that used the Luminex-based assay to study the stabilization of the convertase and augment formation of the convertase, patient sera where the nephritic factor had both functionalities, the ability to augment formation and stabilize a formed convertase, ultimately was correlated with a composite renal outcome. So there's beginning to be some data telling us about the long-term implications of these factors. So thank you.
Thank you, Brad. That was fantastic. We'll open it up for questions right now. If anybody has any, yes, please go ahead. Actually, I'll bring the mic over to you.
Thank you for the great presentation. I'm Anu Kaskin. I'm from Toronto. Actually, I'm not sure if this question is for you or for Carla Nestor, but what about the study you did with your students? So was it ELISA-based or like what was the method you followed?
SPR, surface plasma resonance, yeah.
Thanks.
And by the way, normal might have been overstated. They were college students.
Any other questions? So Brad, I actually wanted to ask you, you brought up some really interesting points in your talk about, what labs, what kind of testing they're doing. So could you elaborate a little bit? There are 3 or 4 labs, at least in the United States, that do this testing. And it is very obvious that clinicians who are ordering this do not know what is being what is the actual mechanism they're testing. So what do you recommend to people who are ordering? I don't think it's always clarified in the report either. So what are your suggestions for that?
Yeah, I guess I would say rather than highlighting one specific nephritic factor assay as being superior to the other, I think the most robust way to do it, and without implicitly or explicitly endorsing any particular lab, the MORL lab at Iowa does a panel of those different assays. The more ways that you can look for nephritic factor, I think, is the more